Hello, my name is Brooke Briesemeister, and this is my DNP project for the Maryville School of Nursing, graduating class of spring 2025. My project is called Trauma-Informed Coworkers, translating the trauma-informed framework to team member interactions. Starting off with my committee, of course, my chair is Dr. Stegman, my second reader was Dr. Brunworth, and I had emphatic support from the Chief Nursing Officer and the Interim CEO at the facility where I conducted my project. It's a little bit of background. It kind of all starts with what I was interested in as the author. So I noticed a significant nursing phenomena before I was a registered nurse as like a different kind of direct care worker, but in general, staff are leaving the profession at an unsustainable rate. And just a quick Synol search will show you that this phenomena exists globally. So it's not just in the United States. It's a problem because more experienced staff are correlated with better outcomes. So in general, we want people to stay at the facility, stay in the profession in general, to make sure that we are meeting our patient outcomes, because we always want to provide the highest quality care. So I work in behavioral health. You'll hear my background in a second. It is a unique specialty with its own challenges, but in general, the rates of trauma, burnout, and moral distress are pretty even among specialties. I would say behavioral health and the ICU and the ED are the top three. But in general, nursing in general have higher rates of trauma than the average career. So it makes sense that nursing in general is experiencing this, not just behavioral health. And that's why some of the research can be generalized across all nursing specialties, even though they took place like in an ED or in an ICU. So from there, my project goal is to create a program that really, it just is inspired by resilience. I want what's best for myself and the staff and the patients. I want what's best for the facility. I want what's best for the reputation of the career, the longevity of behavioral health care, regardless of, how hard it is to work there. So a little bit about my background. I went to undergrad. I have my bachelor's in nursing from the University of Wisconsin. I got that in 2018. So by the time I graduate, I will have about 7 years of nursing experience. I am a board certified psychiatric mental health RN, which by those standards makes me an expert in behavioral health nursing. I've also only ever done behavioral health nursing. So my entire nursing career is in that. I've worked in the inpatient setting, the partial hospital program setting. I've been a nurse educator, and I've taken faculty roles at a local university. So mental health is my jam, for lack of a better term. I will never leave. So if I'm not going to leave, I might as well leave the profession better than how I found it. And it's true, I have, a strong passion for this population. I really enjoy them. I think they need more help. And I think this project comes at an important time where I live, especially in the county. So the mental health complex where I live, they lost their funding by the state, and it was distributed to community-based resources in the area, as well as some money going into a brand new inpatient facility. And so that was a lot of turbulence, a lot of change, and a lot of struggle, because in general, the most acute patients go to the county complex, and now that that does not exist, there's a lot more burnout, there's a lot more distress. Other facilities are getting patients they've never seen before, that require resources that they've never had before. And in general, the local hospitals have been flooded with significant change in terms of acuity. So this could not come at a better time. It's a clear need to address burnout, moral distress, and institutional betrayal. More on those terms as we go, but they are all separate. So the purpose of this project is pretty tangible. I want to increase staff retention and decrease the open full-time equivalents. So basically I want staff to stay at the facility. I don't want there to be open positions that ever cause a unit to run short-staffed. In this way, high quality, experienced, and professionally fulfilled team members will be who you meet if you need inpatient treatment at this facility. And the way I do that is to increase emotional safety and well-being. A hurt, a wounded, emotionally staff member cannot provide the highest quality care, and then eventually have feelings of not being fulfilled, that feelings of being burnt out, that feeling of moral distress where you cannot provide the same empathy and unbiased care and quality of care because of the emotional state that this traumatic work has put you in, seeps in until you eventually leave the facility or start, getting into trouble and discipline. So I'm hoping that this approach will then also align with the goals of the institution, related to operational things and that. So supporting the direct care workers can have a ripple effect for the goals of the facility related to financial and operational goals. Because at the time this project was implemented, the facility that has a capacity of 96 inpatient beds was only running at 36 related to staff shortages. So the community doesn't want that, the other staff doesn't want that, and of course administration doesn't want that. We want a hospital with that capacity to be used. We do not want patients not getting care. We do not want them boarded in the emergency departments for over 24 hours waiting for a mental health bed. We do not want to have to prioritize who is the most acute when they all meet inpatient criteria. So in general, having the staff, keeping the staff, and keeping the staff satisfied will then impact the community it serves. So a little bit on the literature review. I used 10 works in my paper that had 3 common themes. So theme 1 is trauma-informed leadership. In full transparency, when I decided on this project, I've always been in love with trauma-informed care and wanted to generalize that into like a more organizational structure. I thought that was a new concept. I thought I was going to be the first person who has ever thought of it, when it is very much not true. Trauma-informed leadership exists in office buildings. It exists in non-healthcare settings. Most commonly I saw in the literature in like outpatient therapy offices, but it wasn't in a way that only supported the patient. It was in a way that supported the staff as well. So this is not new, but I would say it's not largely translated into the policy and procedure of a healthcare organization. But in general, trauma-informed leadership includes leadership style, policy, organizational structure, education, and the overall architecture. Of course, if you work in behavioral health in an inpatient setting, you know that the therapeutic milieu is designed on purpose in terms of colors and chairs and other things that is inherently trauma-informed because it's calming. But the nurse's station doesn't always look like that, right? So we've seen trauma-informed architecture and trauma-informed organization in other settings. So it's very possible for healthcare. Theme 2 is the healthcare workers' mental health. In general, you see a significant dip in a nursing student and nurse's mental health. It starts about junior year of college and it gets significantly worse well into the first year of the nursing career. And that's related to a concept called institutional betrayal. It's when you have to go through these institutional requirements to get the job done, aka get a nursing degree, but they do not support your mental well-being. So that is what institutional betrayal is. And in general, we see significant rates of trauma, anxiety, and depression in the first year of nursing career. And that's the time where we see the majority of the nurses leave, which is within year 1. That's shocking and not sustainable. We cannot, create high, well-educated nurses fast enough in general related to our universities. But then for them to leave within the first year is shocking. But in general, although this is a documented phenomenon, you've seen required debriefing and brief interventions work well for nurses, especially in their first year of their career. And last but not least, because this is why we're all here and doing what we're doing, is patient outcomes. Trauma-informed institutions, so those office buildings and psychologist offices and those pockets of healthcare where the intervention was changing trauma-informed leadership or policy, shows decreased morbidity for patients and increased patient satisfaction, which is like 2 of the 3 things I see most on patient surveys that we can use as outcome indicators. So it works. There is significant documentation that it works not only for the staff, but for the patients. A couple theoretical frameworks. In general, I was inspired in previous classes by Jane Watson in caring theory. And I think the principles of trauma-informed care were also inspired by caring theory. So in general, the inspiration for the project itself, besides being inspired by trauma-informed care, is informed by the moral act of caring rather than the feeling or the emotion. Nurses are great as a profession. As interventions, of course, we do interventions that include medications and other things, but we also give interventions of caring, which can be direct and tangible and supported by caring theory. And last but not least, implementation of the policy related to my project was inspired by Lewin's change model, starting with unfreezing. If you know about trauma work, you know that patients or anyone that experiences trauma can either fight, flight, or freeze. And I think a lot of the nursing staff are kind of frozen in this chronic traumatic state that does not align for changing practice and changing some of those negative thoughts. And so in general, I picked Lewin's because of that freezing related to trauma work. I wanted to unfreeze the staff by providing support, showing their support in their role in the changing, and then refreezing after some of those negative thoughts and really just autonomic dysfunction that comes with a trauma response in the refreezing stage. So into the project itself, I used quantitative design, and it is a quality improvement project. It is a pre and post intervention style, which means I found a sample size, implemented the intervention, and then looked at the sample at another time period. The intervention is an educational session that I created called Trauma-Informed Coworkers. It's the whole time together was 90 minutes, but the lecture lasted maybe 60 with time for questions. I had interactive case studies and a post-test. So I offered these educational sessions multiple times. I think I probably had up to 12 until all 60 members that I identified within the inclusion criteria attended. So inclusion criteria includes registered nurses, licensed practical nurses, and mental health technicians that are full-time, not agency or temporary staff. Oh, not full-time, but permanent staff members. They don't have to be full-time. They could be part-time. It doesn't matter what shift they worked. I came in at 10 p.m. I came in at 5 a.m. And in general, that was done. Then, of course, no human subjects. which you will see in the sample slide. So here we are, like I said, RNs, LPNs, and mental health technicians. So 60 staff members received the intervention, so that is the pre-intervention size. And related to turnover and the rapid rehiring process that the facility has in place, even though there was turnover throughout those 6 months, 60 staff were then employed again at that snapshot post-intervention time of 6 months later. So kind of shocking that my pre-intervention and my post-intervention sample size were the same, but they were. So data collection was actually done with an internal software within the facility. I was working at the facility at the time, so I had a direct relationship with the Director of Human Resources and the Human Resource Generalist, where they showed a software that they updated daily with both hiring and terms. So all that data was updated daily, and then monthly it was already sent to the corporate within the institution. So those numbers were just then sent to me. Retention in this place was measured by the employees who were not termed, so the employees that remained in the facility over the number of employees, so like a proportion or a fraction. And then the pre-intervention and the post-intervention fractions were compared using the upper tail z-test for the difference of two proportions. Here are the results. You can see I have a 95% confidence interval, so even if it was on the fence in terms of outlying, that confidence interval shows it's pretty accurate. You can see that p-value down at the bottom of 0.6155, which falls well within those critical values, so there's no question they're related to the confidence interval. So we do not reject the null hypothesis. This data analysis suggests no significant correlation between the intervention and staff retention rates, pre and post. So at first I thought that was a bummer, and it was just like, okay, this doesn't work. This facility needs more help. And it was hard to find like real suggestions and conclusions and recommendations until I broke it down by demographics. So you can see the pre-intervention terms by job title at the top and the post-intervention terms by job title at the bottom. Again, I looked at direct care staff, which include RNs, LPNs, and MHTs. And this gave me a lot more information. So you can see the MHTs are disproportionately leaving from the facility, and no LPNs left the facility at month 1 or month 6. I then was curious and looked for trends across the 6 months, and not a single LPN quit during that time. More to come on that. Of course, this study is not without limitations. Like I was getting to before, measuring data at 2 distinct points rather than the intervals kind of miss an opportunity to identify the trends. Of course, I looked back anecdotally about the LPNs, but that was not included in the research design. And then in general, there was no standardized way to reinforce that the educational information was retained and translated. So that requires further information, probably more like staff testing of knowledge that can use a similar study design. And in general, I do worry about that related to general engagement when I did the intervention, as well as this was like put into the annual education requirements for the facility. And I know sometimes if you are told to do something, you can have a different level of engagement and motivation, especially when you're thinking about what you have to do after this. You have to get, who's covering your patients, you have to get back to your shift. It's a tricky environment for sure. So in general, like you saw in the data analysis, there's no correlation between the intervention and staff retention. And this is something that does not reflect the current literature. I did not find any literature where they implemented an intervention and it was not effective. So that's interesting, related to either the intervention will not suffice, for the needs of the direct care workers, or that this institution could be some sort of an outlier that requires more help, especially related to, again, the trends in closures of other facilities, this being a new facility, the first one of that organization in the state, changes in acuity lately. However, like I mentioned, the demographic breakdown of the data showed very clear need for more research. So disproportionate MHT turnover, I would like to make the inference that these nursing interventions that we do that help nurses may not help ancillary staff. So we think of nursing staff as the nursing and the nursing assistants. This is another term for a nursing assistant. It's an unlicensed nursing assistant within behavioral health. But I don't think we can lump them together for interventions that help with burnout and longevity related to this. It didn't help them. And so there was maybe one work within the literature review that directly talked about ancillary staff. They used peer support, which fits into this category. But in general, we should focus on what the MHTs need related to the significant amount of turnover that they experience. So I don't think nursing interventions are as generalizable as we once thought. And then the fact that not a single LPN quit during this entire data collection period shows that there is something to this role. I think some qualitative or ethnographic data related to the LPN and why this works, why they feel, fulfilled, and why they are not leaving should be studied as well. So then we can take those principles and generalize them to the MHTs and RNs. So implications for, of course, future research and practice. I talked about a need for an intervention that is actually effective, that shows correlation. The research shows competitive pay, 12-hour shifts, and changes in organizational leadership, policy, and procedure as all things that can potentially have correlation at this facility. Again, I would not like to, in the future, I would not like to group MHTs as nursing staff. I think they need their own individualized interventions. And then, of course, the role of the LPN should be studied. There's something to that. Then implications for practice. This is related to sustainability. I mean, this shows a monthly turnover rate of 10 to 11.67% of direct care staff. I will say the turnover rates of therapists and environmental services and physicians are similar across the board at this facility. It's not sustainable. So we need policy change that has an indirect effect on practice. In conclusion, nurse researchers have an obligation. This is a real call to action. Turnover, burnout, and moral distress is intervening with the longevity and the reputation of the profession. This is seen in behavioral health, especially as direct care workers experience trauma and deserve the same framework and support in their workplace that they provide to their patients. A lot of staff have the same experience as their patients. The only difference is if one has a key and one is not. One is in crisis and one is not. Why do the staff not deserve that same respect? So the educational intervention about a trauma-informed workplace was implemented, but it was not enough. It did not suffice to increase staff retention, and future projects should search for, first, an effective intervention for all direct care staff, or should target MHTs, or future projects should explore the role of the LPN. Of course, future practice includes structural change in policy and procedure that can align with the purpose and aims of the original project, which is to keep direct care staff emotionally safe so they can stay at the facility, provide high quality care, and be emotionally fulfilled. And here are my references. Thank you.